Good morning. My name is Rebecca Griffith. I'm the ED DPT. Welcome to this episode of Admitted or Not. We have with us today Dr. Naveed Shan for our Feature Friday, and we are going to kick it off by asking him to introduce himself.
Hi, my name, like I said, is Naveed Shan. I'm a physical therapist out of Phoenix, Arizona. I've been a PT for a little over 4 years now. I started immediately out of the into the emergency department. It was kind of my dream setting, and I was really fortunate to get the job. And I've been really happy there. So I specialize in orthopedics and sports medicine. I got my OCS last year, and I just sat for the SDS exam. And I have a strong passion for this. In my spare time, I do a couple things. I compete in strongman. I think I'm probably retiring soon, if not already. And I'm also a strength conditioning coach. So I'm currently working with a few pro MMA fighters within the ONE FC and UFC organizations.
Wow. So you work full-time in the emergency department?
Yeah.
And you're strongman?
Uh-huh.
And you run your own business?
Yeah, run my own business with strength conditioning and PT.
And you're almost double board certified?
Yeah, almost double, hopefully next year or next month.
That's amazing.
Get the news.
Congratulations. And where did you go to school and when did you graduate?
Graduated December 2017 from Northern Arizona University. Got my DPT there. And before that, my undergrad was at ASU in Tempe, Arizona.
Wow. So how did you even know? I mean, you said that this was like a dream job for you. How did you even know about it?
Yeah. So I was actually Dr. Mike LeBeck. He was one of our faculty at NAU, but he's a big advocate of EDPT. He lectures all over the country. And one day he came into one of our classes, and he lectured on the field. I thought it was really cool. I wasn't sure. That was my third year. I wasn't sure what direction I was going to go. Outpatient orthopedics and my clinical rotation kind of left a bad taste in my mouth. I got really good at insurance fraud, and I got really good at seeing 30 patients a day.
Wow.
And I kind of didn't want to do that.
Yeah.
But Dr. LeBeck came in and he spoke to us, and I was like, that's where I want to be. And, luckily it worked out. My last clinical rotation was in an inpatient setting, and they had an opening, and I applied, and I was lucky enough to get it.
Now, was that position like existing in the ED, or did you create your program?
So it was an open position. They had never they were trying to fill that position, but no one had ever done that at that hospital. And so it was kind of me starting the program as a new grad, and I really enjoyed it.
Awesome. How was that, starting a program as a new grad? Because I get asked that a lot. Like, how do you even start?
It was pretty tough. I mean, as you know, the ED kind of works in almost like an algorithmic style. Someone comes in with a stroke, they do A, B, C, D, E. Someone comes in with an MI, it's the same thing. It's always these like kind of very step-by-step approaches. And they had no idea what I did. For my first day, I introduced myself to the medical director. And he was like, "Oh, nice to meet you. I'm glad you're here. So what is it that you exactly do? I heard that maybe you can help with migraines."
Wow.
So he had no idea, and not to his fault. I mean, it's something that was completely new in that setting, and I was really happy. It took a lot of work that first year of getting buy-in from all the providers, making sure they knew I was there, they knew what I could do, and it also took a lot of me getting out of my comfort zone, because I'm kind of naturally introverted. I don't like talking to people. I don't really introduce myself or go up to people in social settings, and so it was really tough to kind of put myself out there, especially as a new grad who, looking back 4 years ago, I was absolutely clueless on, how to do anything. And so it took quite a bit to get there, but I was pretty happy. I put myself out there in the hospital setting.
That's amazing. So if you were to go up to a physician, like at a conference, what's your elevator pitch? Like, what's your one-liner about what you do?
I don't think I've ever come up with a pitch or had to explain myself. It's usually like case by case scenario. But usually the first couple times it's like, hey, Dr. Burns, I saw you had this patient with some back pain. And I was hoping I could see them. And they were like, and it's almost like it, it was a joke the first few times. They're like, well, what are you going to do for them? And then they had no clue. So I had to explain, well, we can try a bunch of different things, but it has, we can try manual therapy. We could try repeated motions. We could try, just talking to the patient, giving them different exercises, whatever it could be to try. And, they have nothing to lose other than maybe some reduced throughput time. But yeah, I don't know if I answered your question.
No, yeah. Do you find in your hospital before you started and how your practice is now, do they do a lot of imaging now that you're there? Or do you feel like you've had an impact on that?
I thought I would. That was like the initial pitch for, EPT was, we reduced imaging. But I realized a lot of it is, it's giving something to the patient. Like, yes. Oh, they came in, their back hurts, and okay, yeah, we'll x-ray it because it's no skin off my nose. And two, it's kind of a liability thing. That, the doctor wants to say, yeah, we got the imaging done. And some people just, some physicians unfortunately just overutilize imaging. Like someone, gives them a weird look and they CT them from head to toe. So I'm not sure.
I'm not going to deny it. I've seen that happen.
Yeah. So I'm not sure if I made a huge impact, but I've definitely, there's been some instances where I recommended certain types of imaging versus others on certain cases. And, luckily I did.
Yeah. So I think that's part of the sort of crux of having physical therapists in the emergency department. Sometimes we reduce imaging, sometimes we increase imaging. But I would say that I feel like as physical therapists, we're pretty good stewards of those resources as we practice, because for so long PTs couldn't order imaging. So we got good at doing what we could with what we had. Are PTs allowed to image in your state?
No, we don't have any imaging rights outside of the military. I believe Colorado they do though, where you are.
Yeah, we do. Yeah, so we can order imaging here in Colorado, whether you're in private practice or not. Generally in the hospital setting, it's more of like what your hospital will more allow you to do. So we haven't done a ton of that, but I would say our relationship with our providers is so collaborative that if I say, hey, I think this patient needs a CT, it's not a long discussion. It's like, why do you think that? X, Y, Z? Great. Let's get that patient the CT. Is that your experience?
Oh, absolutely. Like there's been so many instances where, it's, and you've probably seen it a million times. You have some geriatric patient come in, they had a fall and they got an x-ray. An x-ray showed it was fine. Yeah. And I try to make them once and they can't take a step. And I recommend, hey, I think we should order a CT scan. And they do. And it ends up being like a pubic rami or sacroiliac fracture.
Man, those pelvic fractures.
I know. Or some neurological stuff, some extremity stuff that really makes me nervous and uncomfortable. And I recommend an MRI or I recommend something further. And, I've never had a doctor, any provider actually, turn me down when I've made those recommendations in the ED actually.
I think that just goes to show the rapport that you have with your team.
Yeah, absolutely.
So what would you say is the hardest part for you working in the emergency department?
The hardest part, there's a couple different challenging things. I think compared to the inpatient setting, you go in, you have your orders, you have your floors, what evals you're going to see, what treatments you're going to take, where as the emergency department, I have no idea. I have no idea if it's a 10 patient day or a 20 patient day.
Or a 0 patient day potentially.
Or a 0 patient day. Yeah. I don't remember the last time I had one of those, but that's a tough part. The other tough part is, we don't always have the best follow through with, these patients might need follow up with a sports medicine doc or orthopedic doc or a physical therapist. And it's really difficult getting them the referrals they need. Luckily, we have a nurse, she's called a nurse navigator. So she's really adamant. She really pushes the patients to make their appointments, sets them up, gives them the time. If they need transportation, she gets that set up for them, which is pretty awesome. But I think those are the two things.
Yeah. So on those days when you say you have a day where you don't have any patients, what do you do?
So I don't just cover the emergency department. I also cover the observation unit. So it's very similar. I don't know if they have an observation unit in at your hospital.
Yep.
Yeah, so I cover that area for evaluation and treatments, but it probably since maybe since the beginning of COVID, I don't think I've had a day where it was slow, where I had a ton of downtime. There's always something to do. There's always patients to see. Yeah, and especially as busy as we are now, there's always there's always patient holds in the emergency department or observation patients to see. Yeah, there's not much downtime for me, actually.
That's great. So do you ever get to the point where you can't manage the full caseload that you have?
Absolutely. Like, especially when it's, I'm supposed to leave at 7:00. There's 3 or 4 more patients to see. And I just can't do it. And I have to talk to the docs like, hey, I have to leave, or I can't say if I see this patient, it's going to take another hour at least.
Yeah.
Or, due to, holds, or, patient holds, and there's the ED is so busy that there's no beds, that the patients are in the lobby, and the triage nurse and the triage provider know that all they need is a physical therapist. Unfortunately, I can't see them.
Because of a space issue.
Yeah, exactly.
Yeah, that's really frustrating. Sometimes I think it would be a little bit easier if there was dedicated space for physical therapists in the emergency department, so that that's not a throughput issue.
Sure.
Particularly if you've had a patient that's been waiting for you for 2 hours and then you're gone. Because I think one of the problems is that, unlike other providers in the emergency department, there's not another shift that comes on, at least yet. There's nobody that comes on at 7 p.m. to 7 a.m. to relieve you.
Yeah.
Do you have other teammates that you can call for help if you need to, or is it just you on your team?
No, it's just me. If it's, there are certain situations where, a person just needs like dispo planning. They just need to get into a skilled nursing facility, or a vestibular issue. We have 2 other vestibular therapists that just need a treatment. In those cases, that they'll come down. But otherwise, if I'm not there, there's no PT.
So what hours and days of the week do you cover?
I work Monday through Thursday, 9 to 7:30 is kind of the standard. Yeah.
And then the other days, nobody covers?
Nobody covers. Initially, the medical provider or the medical director was really pushing for a second PT to cover the weekends. He was really happy with it, especially we have a new geriatric program it's really cool. So they wanted that, but I don't think it's happened yet, or if it has, still in the early part of the process of hiring.
Yeah, because how do you ever take a vacation?
I know. If I do, there's just nobody there, unfortunately.
So generally the way that it works at my facility is everybody kind of takes a day and rotates. And that way it helps us mitigate people getting burned out or people always being there late, things like that. So I want to ask you, how do you keep from getting burned out, or traumatized is not the right word, but we all have seen things in the emergency department we'd probably rather we hadn't seen. And there are also patients that stick with us and can haunt us a little bit. So I want to know, how do you debrief by yourself? How do you manage the social emotional piece of working in the emergency department?
That's a good question. I think COVID made it pretty, that it wasn't as apparent until after COVID. The patient's attitude changed, the public's attitude changed, the way patients treated staff changed. And, we saw a mass exodus of nurses. We saw a mass exodus of providers, unfortunately. That was a huge turning point. I think having other things outside of physical therapy, outside of the emergency department, definitely helped me. And, understanding that I'm not alone, that, even the worst patient, I don't have to deal with the worst of the worst patients. I don't get the verbal physical abuse that the nurses do. So I don't have nearly as much of a mental toll on me as some of the other people. But also having something outside of the emergency department to focus on that, that doesn't, I just try to make sure physical therapy doesn't encompass my life. That's all I have. And I think early in my, I was doing that. And I think it was kind of getting to me a little bit sooner. Uh, it doesn't. I don't really have as much of an issue right now, but having strongman training the professional MMA fighters, treating people at my own clinic, it's a huge. It's like complete ends of the spectrum for someone who might be uninsured and undocumented, but is having this this terrible back pain, and he has nowhere else to go, so he comes to the emergency department. Versus my clinic, which is a cash pay place where I do have pro bono patients, but it's definitely the more affluent upper middle class like patient demographic. So they come in. It's a very large demographic, but having things outside of the emergency department that I work on that does bring me fulfillment as far as work and career.
That's great, because it can be a really stressful place to practice, and you being the only one and doing it full time, I imagine, is a lot. All right.
Yeah, for sure. And it is stressful at times.
So tell me a little bit about how your specialties are playing into the emergency department. Because I'm a board certified neurologic clinical specialist, and I'm working on a fellowship in orthopedic manual physical therapy, because I felt like those were areas I really needed to be strong in to kind of practice at top of scope. So tell me how your specialties come into play.
So orthopedics is kind of my primary strength. And I think it's pretty cool, to go from where I started. And, I had a PA tell me that she didn't want me to see a patient, right? Because she was afraid I'd kill him or do an adjustment and he'd get a vertebral artery dissection to, I'm not sure what's going on, but can you figure it out for me?
Yes.
And so I think that's pretty cool. So and it's not always cut and dry, shoulder, anterior shoulder pain isn't always the same. It's not always biceps tendonitis. So being able to tease things out is where my strength is.
Yes.
And I like being able to utilize that. And I'm primarily, I do love vestibular. I do love all the other stuff I have to do, the treating with the geriatric patients, making sure they're safe, the small amount of wound care that I do, and, trying to diagnose or rule out, some type of serious central like vertiginous sign versus peripheral. I do love that stuff, but primarily I think my strength is orthopedics, and that's what I do in my own clinic. That's what I do in the emergency department. The other thing with sports, I had no idea, but for me at least, with 4 years in the emergency department, the SCS was actually a much easier for me. Yeah, because a lot of it is, sideline emergency management, differential diagnosis with other, medical issues. So I don't say this to brag, but I think the OCS took me almost 6 hours and the SCS took me 4.
That's amazing.
Yeah. And it was really cool.
Well, I think that sports physical therapists, in a lot of what they do, they are emergency physical therapists, right? They may not be emergency department physical therapists, but they are emergency physical therapists. And I think the difference there is that if you're on the sideline, you're a first responder. If you're in the emergency department, you're a first receiver, and they're different roles, but you're going to be able to bring to life both of those.
Yeah.
Do you feel like your emergency physical therapy experience helps you in training your MMA fighters particularly? Like, are you able to support them better, like when they're fighting?
No, so that's a little bit different. Those positions are like the cornermen. So those are typically, they're like skills coaches. So there's guys that are helping with striking or they're grappling, things like that, or they'll have their cut man, which, takes care of any like lacerations or like controlling bleeding, things like that, trying to get swelling down in their face. So my job there is just, like, how can I get them to, punch harder, kick harder, have more endurance, things like that. So it's a different part of my brain. I was a strength coach for about 10 years before PT school. So it's cool getting in that setting, but I wouldn't say there's a ton of crossover. I am noticing a lot of concussive symptoms in these guys, though, unfortunately.
Interesting. Do you offer that as a service, like as a concussion screening service?
No, not as of this time. And to be honest, I'm not sure if they would listen to me if I told them, hey, you need to not fight for a little bit, or you need to do X, Y, Z.
Yeah.
But I'm definitely open to it.
Yeah, I think that'd be a good idea. I do some martial arts myself. I just got my first black belt, and I tell you
Yeah,
what,
congrats.
thank you. It's, what I do obviously doesn't sound as scary as what these guys are doing, because, they're all over the place, whereas I'm like totally wearing pads and things. But I can imagine just a few times that I've like really been like clocked in the face or really injured. It seems like it would be good to have somebody that's looking out for your mental health after a fight like that, as well as your physical well-being.
For sure.
It's kind of scary. That sounds kind of scary.
It is.
Fair enough. All right. I want to ask you two more questions, and then I want you to, I want us to discuss your case a little bit, if that sounds good.
Okay.
Sure. So my first question is, what do you think, based on your experience, makes an ideal physical therapist to practice in the emergency department?
I think there's a couple things. I think you have to be, it's similar to emergency medicine. Like you don't have emergency medicine docs who are just GI specialists or just cardiologists or just XYZ. They might have something they're interested in, or they have a focus, but you really have to work through like every scope of your practice. You have to remember, every type of issue a person can come in that could be potentially an emergent issue. Same thing with physical therapy. You have to be able to use your, your neural brain and clear out vestibular stuff. You have to be able to, be a great inpatient therapist where you're making sure that the patient's safe, or they move adequately to be safe at home, or whatever, get them the resources they need. And you have to have good orthopedic skills, not only good orthopedic skills, but good differential diagnoses skills.
100%.
So it's kind of scary, the amount of patients I've had, they came in with sciatic pain, and you're talking to them and they're like, yeah, I think it's just really bad sciatica. I went to the chiropractor, they got an adjustment. Oh, but also I've lost 20 pounds in the last 4 weeks. And I feel like I can't get up off of the toilet. And then they do a CT scan and, it's cancer with mets of the spine.
Yeah, I had a case similar to that with a patient who'd been experiencing homelessness recently, and she attributed her ongoing back pain to sleeping on the cots at the shelter. And she'd had a wound on her shoulder that wouldn't heal, but she's like, no, I've been picking at it, and it just won't heal. And, yes, I've lost weight, but like I've been homeless for the past month. Like I'm not surprised, but her back pain just really was not very mechanical. But she had abdominal pain that kind of reproduced her back pain. So in evaluating that and then sharing that with the primary team, she was ultimately diagnosed with metastatic melanoma that had come from this skin wound that I had looked at that was now all through the peritoneum, and she had a pathologic spinal fracture, and like all of these things that could easily be written off. But with a musculoskeletal specialist who can really identify, is this mechanical low back pain or not? And in this case, some of it was because she had that fracture. But what I learned most from this case was the fracture site wasn't giving her any pain. And I kind of collaborated with the neurosurgery team, and I was like, why am I missing this? Like, it doesn't seem to hurt her. And he said, when you get those pathologic cancerous fractures, by the time they kind of fall apart, like this woman's had, it doesn't hurt because it's just been slowly degrading and crumbling over time. It's like your house, right? Like by the time you notice that you have a foundation problem, it's way too late. Like you missed the early warning signs. So she was ultimately, in this case, admitted. When we talk about admitted or not, she was admitted for definitive management of her melanoma. But that was one where we could have easily said, hey, here's some range of motion exercises. Here's how I would suggest you try to sleep on this cot at the shelter, and I wish you the best. But hopefully she had a good outcome. I think about her often, actually.
Yeah, I'm sure. Hope she's doing okay.
I do too. I really do. But I think that's another thing. My last question for you is, how do you get past, like as physical therapists and in PT school and our clinicals, like we really are relationship builders, and we like to see this trajectory of care. We like to manage people's outcome. But in the emergency department, if everything's going the way it should be, you should only see a patient one time. Like we shouldn't be making long-term relationships with our patients. So how do you manage that aspect of not knowing what happened to your patients and having to meet new people every day, particularly as an introvert. I imagine that would be hard.
Yeah. Oh yeah. I'm exhausted when I get home.
I
Yeah.
bet.
I don't like talking much when I get home. Um, that's a good question. How do I manage that? I'm really good at connecting with patients. I'm really good at setting a good relationship, even if it's just that, that 10 to 30 to 45 minutes you get with the patient.
Mm-hmm.
I'm really good at connecting with them, with getting that buy-in and, getting, I'd say the vast majority of patients, I make sure they have a follow-up, whether that's, establishing PCP for the first time, whether that's getting them into our sports medicine clinic, whether that's getting them into ENT or to neurology or something like that. Just making sure that, they know someone is looking out for them, because, some of the providers, not to their fault, but they have, 10, 15 patients at a time. They can't spend that much time eye to eye with the patients, but I have that time to, this is why your arm is feeling this way. This is why you have back pain. This is why, you get really dizzy when you turn that direction. I sit there and I explain to them, and, I think I think patients appreciate that, because, nurse comes in, they go out, the doc comes in, goes out, the imaging tech picks them up, drops them off. They don't really get much face-to-face time. So I really value that time I get with the patients that I have with them. And I think that's where I get that, that fulfillment, where I might not see this patient 3 days a week for, 4 to 6 weeks. But, I'd like to think that, people coming in, I help them in some way.
I love that. And we've been measuring patient satisfaction recently as part of a new pilot program, and it's stressful. Like, I feel like I go in there and I'm like, can you fill out this? And it's just about me, right? Like, and I have to be very explicit. This is not about your whole emergency department visit. This is just about your physical therapist. Yeah. And then I just ask them to leave it in the room so that they don't have to fill it out in front of me. But there are times when I feel like I wasn't very helpful and I didn't fix the problem. But then they will write very satisfied and write like improved quality of life, like great explanation. So what I've learned is that connection time and that time we spend educating patients and that time we spend really being thorough in our examinations and our connection with the patient, I think those are the things that set us apart in the emergency department.
Yeah, absolutely.
So whether we fix it or not, I think we're still providing satisfactory patient care to those patients.
Absolutely.
All right. Are you ready for admit it or not?
Sure.
All right. I want you to tell me a case you had, and I'm going to try and guess what you did and how it turned out.
Okay. Let's see. There was a 24-year-old male. It was a really slow day, so I was kind of looking at the tracking board, trying to pick up a patient if I could. But it was a really slow day, and it was towards the end of my shift. It was a 24-year-old male. It was kind of a weird story. He was getting in the elevator at work, and the elevator, as he was walking out, the elevator door closed on him, and he fell, and he was complaining about left knee and left wrist pain. They did x-rays. I mean, he was weight bearing. He was fine, like very low likelihood of anything serious. But as I was talking to him, he kind of mentioned, this knee pain, we got his knee to feel better. We got his wrist to feel better. We put a splint on him for his wrist, and we were discussing, kind of how he was feeling otherwise. And he was like, yeah, I have this weird headache. And I that kind of headaches, I don't know why. I do love headaches. I like treating headaches. So those always kind of intrigue me. So I was asking him some more questions, and he was like, yeah, I have this really bad headache since this happened. I don't know what's the cause. I was like, did you hit your head when you fell? He's like, I don't know. I must have, because this is probably the worst headache of my life, which is also like kind of
red flag.
Yeah, red. Yeah, the most reddest flag you can imagine. So I was talking to him, and he did a quick neuro screen. He had a spontaneous nystagmus, couldn't focus. He said he couldn't focus. He said he was having blurred vision, spontaneous nystagmus. Just talking to him. Everything else came back pretty normal as far as his neuro exam, but the spontaneous nystagmus, biggest headache of his life, those were both two very concerning things. So I talked to the provider, and luckily it was not that, people kind of ignore me, but when I mentioned something, Some providers, they order everything, some don't.
Right.
And so I mentioned to this patient, and I mentioned to the provider, I was like, hey, this guy, I think he has a concussion or something worse. He mentioned that had a worst headache of his life. And I saw a few other things that made me concerned. So she goes in, she talks to him about 30 seconds. She puts in the CT order, and the neuroradiologist calls her, and she's like, hey, I think this is what it is, but I've never seen it before in my life. And it was pituitary apoplexy.
What? Okay, so explain to people what that means, because that is not where my head was going. Like, okay, maybe we fell and hit our head, and maybe there's a little subdural happening here. So tell us what that means.
So it was, I believe it's, I could be wrong. I think it was a tumor or some type of lesion at the pituitary gland that ruptured.
So that, do you think, is your hypothesis for this patient that he fell because of that, or that was secondary, just unrelated?
I think it was secondary, unrelated. He didn't really have any coordination issues. He didn't have any balance issues. I think it was just right place, right time.
And like no cognition issues during your evaluation?
No, just pain.
Wow. So I think that's a great case example of admitted or not, like using the physical therapist's judgment to spend that extra time with the patient, to get that trust and buy-in so that you hear that little bit extra story from the patient, and then really able to use that relationship with the provider to get the patient the right care that they needed. So I'm voting admitted.
That's right. He was admitted to the neuro ICU same night. And I think neurosurgery saw him, they cleared him for activity, and they weren't going to perform any surgery on him, but they gave him some, I think it was a steroid, some type of steroids, and he was released like 3 or 4 days later.
Oh, it's crazy.
Yeah.
Well, good catch. That's amazing.
Yeah.
All right. Well, I appreciate you being with us today. Thank you so much, Dr. Shan. Anything else you want to add?
No, just thank you for having me. Thank you for doing this and being a good advocate for the profession in this field. I'm really happy to, sit here and talk with you.
Thanks so much. Have a great day.
You too.